please help me welcome Dr. Kanall.
Good afternoon, everyone. I'm so honored and humbled to be presenting at the first dental therapy conference in Minnesota. And I hope each one of you got enough of caffeine as I walk you through wonderful stories of our pilot progress and perspective. If you didn't get a chance to have a cup of coffee, please go grab some. And as you can see on the slide, a happy picture, colorful picture of our communities across the lifespan, smiling. This is actually a token of appreciation on behalf of Minnesota Department of Health to each one of you in the audience who has helped us not just address the burden of the disease, but helped us adding cultural competency, diversity to the workforce, helped us do the community clinical linkages, address the burden of dental disease, and also helped us move upstream because we have envisioned a community where you see all of us smiling because prevention could really be happy, right? So I have three broader objectives for today's presentation, so please help me achieve them by the end of the 30 minutes that I have. So the first objective I have is to bring about that public health perspective to access, because as I'm talking to many people or decision maker at the state level or national level, first question I get, and I'm sure all of you get, is how are dental therapists improving access to care? So it's important for us to take a moment to think about what this access is all about. The second objective I have for my presentation is to talk about our dental therapy data project that has informed about what our dental therapists are actually doing and the impact that they've been creating. And the third objective is to talk to you about the dental home demonstration project, not really the project, but the lessons that we've learned from the work group and how we should move forward more strategically so that we are more equitable in oral health promotion. So access is central to the performance of healthcare system across the globe, right? And this access that we talk about is a very complex notion also because we don't agree on a common definition. So some of the authors or researchers think that access is really being able to identify healthcare resources and also being able to utilize it in situations where I am perceiving need for some sort of care. Whereas some other researchers think about access as something that is really affected by coverage, services available in the community, workforce, and timeliness. So that is the reason why I feel like complex, it's really complex for us to dissect the different aspects of access. So this is a picture of me practicing dentistry in Nepal. And we did hear a speaker talk about how you could actually take your backpack and go and do GIC, ART, a lot of things. So this was one of those days where I was totally into the clinical dentistry, but more in a community setting. One of the reasons why I brought this picture is to tell you this is exactly who I am. Second reason why I brought this picture is to tell you that access is really real. Third reason why I'm sharing this picture is I want you to see the vulnerability in my eyes. Not sure if you can actually see that there. As I'm looking into the eyes of this little boy. Fourth reason is that I want you to see the hope this child has in his eyes. And look at the dental chair that I have back home. It's really not even a chair, right? And look at the mom who's standing behind both of us with lots of hope, but deep inside my heart, I know that resources are finite and needs are infinite, right? So this was a situation I had. This was a free dental camp in one of the villages of Nepal where this child had pain and infection in one of the permanent molars, and the only option I had was extraction of the permanent molar. How can I do it? If I don't do it, there's no way I could tell him, oh, come to my clinic. There's no clinic. I can't tell him, oh, go to your nearest hospital. There are no nearby hospitals, right? So the earliest he could get to even a little health post would be hours of walk before he even finds, or his family finds, a transportation, a local bus to get to the hospital. and I did extract the permanent molar for this child, and that was the time I felt that as a clinician you might be able to change, like do excellent dentistry, but you are not able to change, alter the various social determinants of oral health that comes into play when you are making these kind of decision, right? So fast forward to my journey here in the US, I'm thinking that I have different accent, but everybody in the US can speak English. I was so wrong. I felt, oh, I didn't have car at that time, and I thought everybody else, especially patients visiting these sliding fee clinics, would have cars. But I was the one, as a volunteer, handing out those bus passes to people because they did not have bus passes. There was no way they had insurance. They did not have the ability to pay $5 to $10 here in Minnesota. There was a time when I was part of a team providing free care, but a mom still refused to show up for her daughter 4 times. And I asked her, like, what is happening? And she said, one, I couldn't take flex time from my job. Second, this is Christmas time, and I want to make sure that my daughter has a Christmas present on her table. That feeling is more important for me than to have our cavities fixed. So I think I can totally relate to Mary Otto's book, where she talks about inequalities in oral health and how access has really been so real. And again, when I read about Mary Otto's book, and every time I think of Demonte Driver, a 12-year-old boy who died of complication that started with a tooth decay, I feel the same vulnerability in my eyes. So $80 tooth extraction could have saved him. $1 fluoride varnish could have prevented the absence to begin with, right? But whether it was Nepal, whether it was the US, one is developing country or underdeveloped country to one of the most developed countries in the world, access has not changed. The social determinants of oral health have not changed, and I remain vulnerable from there to here. The other thing that I'm seeing in my role is over half of Minnesota counties have dental workforce shortage areas. It's already given to us. On top of that, there are barriers to oral health care that I already talked about, whether it's oral health literacy issue or transportation, childcare, language. There are so many barriers that our communities are facing. So it's time that we think about not just bringing patients into the clinic, but we should be going out to the communities to make sure we are promoting oral health in places where our people are born, they live, and they grow. So what happens with these kind of access issue is that women with lower incomes are less likely to receive dental care during pregnancy in Minnesota, and the difference is twofold. And women or pregnant people from low-income families are less likely to receive oral health information from their medical provider as well. The trend continues, and less children under 6 are going to the dentist. So there are a couple of data on my slide here. One is from the telephone survey, which shows that 55% of our children are being seen by the dentist. But if you really look at the claims data on the right, and if you look at the less than 1 category here, it's less than 1%. And first tooth, first birthday is one of the most important milestones in our life course approach, right? So this is an equity issue that we are facing at the state level. So even though the data tells us that only 13.2% of children and adults in 0 to 17 years category do not have dental insurance, then why is it that we are seeing half of Minnesota third graders with tooth decay, and 17% of them have untreated tooth decay? This is our primary data collection. And there's sharp disparities between these children when they come from cohorts, if their families are low income or they belong to certain races. So that means that just having an insurance is not going to guarantee care, right? The same trend continues, and when we looked at the mouth of older adults living in nursing home facilities, at least 42% of them needed some sort of dental care. And we were not even able to capture the burden of dental disease among our older adults who are in our homes, because not everybody is in the institutional setting. And access to dental care is essential for both oral and overall health. It goes beyond something like, oh, I missed a dental appointment. Oh, it's okay, I can go without cleaning. No, it's not as simple as that, right? That particular cleaning or the intervention we are doing manages the inflammation that is the kind of linkages between your oral and systemic health. And on top of that, our data shows that many dentists are planning to retire in next 5 to 10 years, right? And we already know that dental professional shortage areas that also includes rural areas are already facing difficulties to recruit and retain dental providers. So then what we did was we looked at different frameworks for increasing access, and we already have such innovative dental workforce model that enables our dental therapists to step out of the traditional brick and mortar clinic and improve the access. But we also found out that when we talk about these equitable framework to improve access, there are 5 dimensions that we need to understand, starting from approachability, acceptability, availability, affordability, and appropriateness, which means that do I know as a patient what kind of services are there in my community? Do I have the ability to utilize them because I know it's going to improve my oral health? To factors like social, cultural acceptance. So if I'm a person and I have my religious beliefs or some restrictions, or I have preference to be seen by a female provider, and I have only male dental providers in the community, it may not be culturally appropriate for me, and there might not be even providers, right? I may not be able to afford dental services, and I might be needing restorative care, but all I can get in the community setting is preventive care. So there's a mismatch of needs versus what is there for you. So coupled with that, there are 5 dimensions or traits of me as an individual: my ability to perceive the need for dental services, my ability to seek it, my ability to reach it, to pay for it, and to be engaged in decision making. So that's when the full circle of access comes into play when you look at it more from the equity perspective. So that's when we decided to conduct a pilot project, because we all know that dental therapy program was launched in the year 2009, but the first official evaluation was done in 2014. So we wanted to make sure that at least we understood what our dental therapists were doing, so that we could at least think about improving infrastructure for dental therapists, and also to advocate for them to be embedded into our medical setting. And trust me, at this time, other states were already asking us, do you know what procedures they were doing? Do you know where they are working? Oh, we heard they are only in Twin Cities. So how are they improving access to care? We had no answers. And there was no way at the state level to identify claims data to see what dental therapists were doing. So we really had to be innovative in how we understand what our dental therapists were doing. So what did we do was we established the dental therapy work group. Dr. Brickle and Dr. Self are the co-chairs, and my Mark Shalmam has been our national chair. So it is led by experts. So the role of Minnesota Department of Health Oral Health Program, or my role, is to facilitate the group. And the group considered ways in which dental therapists can increase access and drive down consumer costs while still ensuring safe, effective care. So for that, we had to start by understanding the reach and impact of dental therapists in Minnesota. So the purpose, there were a couple of reasons why we wanted to do this project. One was, what is that electronic platform that could be used, not at the state level, but at the clinic level, with minimal hassle to our employers, so that we can get some data. Second, what is the minimal data set that we need that can be easily shared between different clinics, so that whatever XYZ clinic is sharing can also be shared by a different clinic, right? Then you have standardization in measurements. So those were the 2 reasons why we wanted to conduct this pilot. And then we recruited 4 very passionate employers of dental therapists. So 4 dental practices participated in our study. They tested data collected and the processes used, because a lot of admin cost is really about those processes, right? How do you enter the data? How do you download the data and then share it with MDH? The focus area was really to understand the minimal data set that we could think that maybe this is what we need to collect at a bare minimum at the state level. And the data that we obtained was from calendar year 2018, and the source was the electronic data system like Open Dental or any other dental software that the clinics were using. So 2021 data showed that these circles show the distribution of dental therapists across the state of Minnesota. So initially, you would see these bigger circles more dense in twin cities, because obviously major employers of dental therapists are in this area, right? So then over the time, we've seen that dental therapists have been distributed across the state. So we are becoming more equitable in how we are increasing access to diverse population. So what we found was 92 licensed dental therapists were in Minnesota in 2018, and 25% of these licensed dental therapists were actually employed by these 4 pilot sites. 30,764 patient visits were provided by dental therapists at these pilot practices, and 1,793 average visits occurred for dental therapists working all 12 months, so more like a full-time dental therapist. 14 of 23 of these dental therapists were advanced dental therapists with at least 12 months of employment during the project period, and 1,931 average visits were there for advanced dental therapists working all 12 months. So of the 4 practices that participated in our pilot, a couple of them were smaller practices, so they served smaller cities, whereas a couple of them were larger providers whose reach was across the city, but also the region. Three of the 4 practices provided services in community settings such as schools and nonprofit, and 3 out of the 4 practices really employed dental therapists in providing emergency services as well. The other interesting thing we did was we looked at the CDT categories, and trust me, this data is coming from the clinic level. So whatever granular level we could get into, kind of, I've tried to be a little bit creative with the illustration. So on the slide, you can see the procedures under different CDT categories. So if you look at diagnostic category, this is what the dental therapists have been providing on your right. And there is a number for the number of procedures performed by the dentist is seen in the blue. So then we looked at the same procedures, but done by different providers type. So what we found after looking at different CDT categories was in both the categories, dental therapists and dentists, both of them were doing many more diagnostic services, and obviously because dentists have broader scope of practice with endodontics, orthodontics, so obviously you would see more services being provided in that area. The other thing was there were two practices were serving patients under the age of 18, whereas the remaining 2 programs served all patients. The only issue was that it was very hard for our clinics to find data and categorize them by race and ethnicity. And I know Dr. Brickell had also brought this up several times, that we need to look at race and ethnicity data because that really shows equitable strategy in how we are improving access to care, because either our clinics didn't have that system set up, or because it was like self-reported line item, we are not able to capture that. So that is the reason why, even though our dental therapists are doing amazing work from that equity perspective, we're not able to capture that as a state because it's a self-reported data. The other common procedures performed by the dental therapist was direct restoration. And if you really look at the perio data, I am not sure why it showed as 0, because, and I went and looked into the more granular procedures under periodontics category. There wasn't anything. So I feel like there are already limitations in how we have our CDT categories set up, and in absence of state not being able to pull this data, it's kind of, there are still like some gaps here. So this is a map from dimensions of dental hygiene. It shows states that are considering legislative proposals to have dental therapy in their dental therapist in their state. And Mark was talking about how Colorado already has a bill passed for dental therapists. The reason why I'm sharing this map is as more and more states are considering dental therapists in their state, we are often called to testify to legislative bodies or share lessons we've learned. And I know I think it was Mark, you were talking how we were Shining Star. So as Shining Star, we need to have our claims to be backed up by data. And even if we are able to tell our counterparts that dental therapists are doing these procedures, they are distributed across a variety of settings, and this is the impact that they are creating in terms of maybe adding more number of exams for our patients, or like helping dentists take on more complex procedures. I think it will pave them road to move forward. That is the reason why it's so important for us to not only collect the data, but share it more at the state level and the national level. And as we talk about advancing equity through systems change, especially being more strategic with our state oral health plan, I wanted to address 4 big questions that are often considered as elephant in the room. And this is a brave space, so I wanted to address 4 questions that I keep getting at the national level and how our pilot have addressed those questions. First question, where are the therapists located geographically? There's no statutory requirement that dental therapists should be working only in rural areas, because there are different pockets, different dental professional shortage areas by facility types or by different income, by the kind of population you serve. So those are also underserved areas, right? The other thing is that there are pockets of underserved population within our Twin Cities that do not have access to care. So, but then eventually we are seeing this data, 2021 provider survey data, that shows that obviously from a time when most of the major employers are in Twin Cities, now there are more opportunities in greater Minnesota, so obviously our dental therapists are moving across the state. So we do not agree that our dental therapists are only working in Twin Cities, even though you would see that listed in many reports, right? So that status has changed. What percentage of their patients are Medicaid? It's a statutory requirement, right, that we have to work with underserved population, and our data showed that 75 to 95% of the patients served by dental therapists in these 4 clinics were on Medicaid. Third question, are dental therapists in direct competition with private practice dentists? And I'm a dentist myself. So, so dental therapists already have collaborative practice agreement with the dentist. So a dentist, we always see them at the top of the team-based care. So as long as there is communication, dentist is in charge of making sure that they're well informed about what happens in their clinic, right? And if you are asking a dental therapist to take on more restorative procedures, you as a dentist can focus more on complex procedures, right? We need advanced procedures also, because in a population oral health setting, not everything is just upstream approach. You need to really manage the disease. So we do not see that our dental therapists are competing with the dentist. It's absolutely collaboration. What is the increased profit margin for private practice dentists that have hired therapists? I did look at some literature. There was dollar value. I'm not there yet that I'm able to put a dollar value there, but simple maths here. Look at the number of restorations that our dentists are still performing. There's so much opportunity here to delegate some of these direct restoration to our dental therapists, and also help them, work closely with patients, help them be more out in the community, move more upstream, have not just patient come and sit in the dental chair. You can bring in individuals for routine care as well, right? So as long as you see value in that kind of collaboration, there is a lot of profit margin that I see. If I were going to start a clinic, I would have definitely seen that financial piece to it. So those were 4 questions that I always receive, and I wanted to make sure that I shared the lessons that our pilot has been able to learn. So future direction for us is that, one, we need to engage our dental therapists at the state level, so we know how they see themselves being strengthened as a workforce. Second is to develop a hub for them, and I know one of the presenters talked about serving as a hub for continuing education. And as we are talking about integrating them in a primary care setting, maybe there needs to be an organization or a body that oversees how dental therapists are deployed beyond the clinic, sort of. So then if there are primary care settings reaching out, there is a centralized body that is answering questions for them. Also promoting the interprofessional collaboration model and talking about those team-based care, educating policymakers to let them know why there are still some administrative barriers that some of our educators are still facing, and there could be some rooms for us to make some policy changes, and considering the big dental home model that I am sure Dr. Brickle might be able to add more to that. And I also know that researchers get frustrated with these kind of ambitious future direction, because there is something called iron triangle in healthcare. So as you can see on the slide, cost, access, and quality are at the 3 corners of a triangle, and they have reciprocal relationship. So if you are trying to increase the access and you want to keep the cost low, we might have to compromise with the quality, right? So you cannot fix one thing by not affecting rest of the 2 variables. But then CMS, I looked at their website, and with their decades of experience, and they looked at like over 50 models, and they came up with a strategic framework to implement their innovation that talks about how health system can achieve equitable outcomes through high quality, affordable, person-centered care. So they've given, if you look at their website, they've given strategies and metrics to move towards that goal. So even though there are literature that tells us that it's not possible for us to improve access and still keep the cost low, maybe it's time that we look at the value-based care and think about those metrics and see how we can still be sustainable in our approach. And dental home model, so we did get, so the state of Minnesota invested in dental home project work group, and legislator gave us as a state some money to convene as a work group and come up with different recommendations. One thing that was very clear to me, as I was also part of the work group, was it's a dental home model, right? It's not competition. Dentists, yes, they are at the top of the dental home model, but there is equally, it's very important for us to do the community clinical linkages. And we are not just talking about fixing cavities. We are thinking about how do we prevent cavities in the first place. And if you're embracing the value-based care model, there is more incentives for providers to get reimbursed for preventing the disease in the first place, for improving compliance, for educating our communities, and just for prevention. It sounds very ambitious, but there are models out there that are sort of evidence-based, and other states have already embraced those models. So we'd like to move towards dental home model, where we see our dental therapists out and about in our communities doing community clinical linkages. And like my first slide, creating those happy communities for us. But what I will warn you is that ripple effect takes time, right? For us to see that profound impact of the work that individual is doing or we are doing as a state, it will take time. So I think we just need to continue to keep up our energy and be positive that we are moving towards the right direction. And with that, I'd like to acknowledge our Minnesota's Dental Therapy Stakeholders Group. Dr. Brickle, Mark is here, and Dr. Self for their leadership and for their wisdom in advancing the work that we are doing. Minnesota Board of Dentistry for helping us with the provider survey data that I could create the map, and also the pilot practices who participated in our study and helped us really understand what our dental therapists were doing and their impact. Thank you.